Dr. David Reich is a real leader in clinical medicine here at Mount Sinai. He will tell you about himself and a little bit about the vision that Mount Sinai brings to this from a clinical perspective.
Yeah. Thanks, Marshall. Hello, everyone. My name is David Reich. I have a few titles here. Maybe we just, should I bring up the slides, sir? I think you should mind do that. We'll go to PowerPoint. Actually, it's I take it back. It's a that one. There we go. All right, while we're bringing that up, yes, exactly. So that way I can just sort of read it off. I seem to acquire a new title every few weeks at this point, but the key one is this top one, this new idea here, which is to be a chief. Should I just grab it? Okay. Be Chief Clinical Officer of the Mount Sinai Health. What does that mean? Well, I've actually been at Mount Sinai for 40 years. Yes, I started really young, but not so young anymore, and started as an anesthesiology resident, and I still practice cardiac anesthesia to this day. And I've been president of 2 of our 8 campuses, Mount Sinai Hospital, Mount Sinai Queens, for the last 11 years. And so I still practice in the OR. I'll be in the OR Friday, working with the chief of cardiac surgery and a resident 3 years out of medical school, so I can still prove to myself I have what it takes, because they can't do much in their first month of cardiac anesthesia. But the point is, I'm still clinical, and that means a lot to me. And hopefully, as I talk to you about Mount Sinai's perspective on this, I'll bring you up to date on some of the work that our group has done, always in close association with Mount Sinai Innovation Partners. And so pleased to see so many of the friends here. No disclosures relative to this presentation. So at this point, I'm going to just give you a little bit of background on the Clinical Decision Support Group, which we grew internally. But we started so long ago that it was 2016 that I called it the Little Big Data Group, because we didn't say AI back then. Back then, everything was big data. So anyone still remember big data? No, you're all too young, right? And so we have a series of products that are live, and of course we also incorporate third-party products. For example, we use both AI Doc and Viz AI with our radiology group. We use various products like Avamo that helps us do AI chatbot interaction with people with our digital engagement group. So this is not meant to be a comprehensive presentation of everything at Mount Sinai, but I thought I'd give you a taste of how we as an academic health system think about this. So I'm going to begin by doing a presentation of a study we did on clinical deterioration. We actually just got it published this year in Critical Care Medicine, and the concept was to create an internal clinical decision support tool that predicted clinical deterioration. Now, you know, there are many tools out there. Epic has a deterioration index, there's eCart, there's Rothman Index, there are a bunch of them out there, but we developed it, and I'm going to tell you why not to commercialize it, but because when we develop something internally, it tends to work for our population. And I'll go into that a little bit later in this brief talk. And so what we did was we looked at the algorithm's performance in 2 medical surgical units, where one more of the medicine patients, one more of the surgery patients, where we used the alerts to bring nurses for low-level alerts to check vital signs more frequently, and to alert what we call the rapid response team. That's like a SWAT team that comes out of the ICU, and that would be for higher level alerts. Then we had 2 other units, one primarily medical, one primarily surgical, where we generated the alerts, but we suppressed them. We didn't send them to anyone. And we had to stop in March 2020. Something happened in New York then. It was unfortunate that we couldn't restart the study after COVID. No one really wanted to, but because we received these results here, we felt we really didn't need to. And what I want you to focus on here, I'm not sure if the pointer shows up on your screen or not, but if you look at the section B here, you see that there's a relative risk of death or in-hospital 30-day mortality, technically, of 0.76 in the 2 units where we add the alert. So basically, there was a 24% lower death rate on those 2 units. A really remarkable result, and that did achieve statistical significance, even though we only studied 2,800 of a planned 6,000 patients. That's why it took a long time to get it published. But the point about that is AI can work, but the the way it works is because we built it into the workflow. And I'm going to keep coming back to the concept of workflow, because we didn't get the nurses burned out. They weren't out there protesting. I have a slide later of nurses protesting. And why were they not protesting? Well, because our chief nursing informatics officer, it was a key person who implemented this, is a nurse. And he worked with nurses. And so bringing the team along was very important. Now I'm going to talk a little bit about malnutrition. Why am I talking about malnutrition? Well, we have a predictor that helps us figure this out. I'll show in another slide why it has a huge ROI for us as a health system that deals with a lot of complex patients that receive tertiary quaternary care. But the reason I show this slide is because I wanted to show the model performance across the 6 hospitals. When we tried to use the EPIC sepsis algorithm, we ran it in the background, and it didn't work at all at Mount Sinai. And I joked when I ran into the EPIC, the AI lead at one of their user group meetings that, well, it wasn't working. So their sepsis index wasn't working very well in the patients in East Harlem in New York City. And, you know, maybe because it was developed on corn farmers in Nebraska. And I thought I was telling him a joke. And he said, well, how did you know I developed it on a Midwestern data set? So, but I think that the joke is not a joke. I might say, remember that expression, all politics is local? I would put forth to you that all predictive analytics are local as well. So think about that, and we obsessively look to make certain that our algorithms work in the different environments, and we'll come back to bias a little bit later in the talk. And the reason this worked for us is we have a group that was focusing on making sure we get paid appropriately at Mount Sinai for what we do. It's really hard. Healthcare has terribly tiny margins, often negative these days. And how do you succeed? You succeed by getting paid for everything that you do at the level of complexity that is reflective of your patients. And here you can see that before the algorithm came about, we were diagnosing maybe 3% of the patients in the hospital with severe protein calorie malnutrition. Well, we were underdiagnosing by about 70%. And every time we code this, it's a major comorbid condition. The hospital gets paid more for the hospitalization. The patient, most importantly, gets the care they need. Malnutrition prevents wound healing. It causes longer length of stay. It's associated with higher mortality. So we were both doing the right thing, and I had an ROI to justify the cost of the team. And that's important because without an ROI, we can't do anything. This was a clinical ROI and a financial ROI. They don't always overlap, but let's just obsessively think about the fact that there's always going to have to be ROI in everything we work on together, and that can be, come about in different ways. Let's talk about delirium. My previous boss, the former CEO, was a psychiatrist, and he was obsessed with delirium in hospitals, and it wasn't a bad obsession. I'm not trying to make any psychiatric diagnoses at the moment, but the fact is delirium is associated with worse outcomes in hospitals. It prolongs hospitalization. It's a real problem. And we had a delirium team, but once again, like that rapid response team, like the delirium team, like the dietitians that have to go and see the patients, how do you get the right team to the right patient at the right time? And the reason I show you this one is because at first we weren't doing so well. I'm actually going to reverse the order of the slide. Oh, that slide didn't show up. Okay, I guess it got deleted out. But the point is that we tried with the basic structured data in the electronic health record to predict delirium. Didn't do so well. Area under the receiver operator characteristic curve, AROC, some people call it the C statistic, only about 0.80, 0.81. It was okay, but not amazing. And then we added NLP, natural language processing, because you discover data in different places. And the data that actually were able to predict delirium were in the notes. And it wasn't the doctor's note or the nurse's note or the social worker. It was all of them put together, because somebody would give you a hint that somebody, was not oriented to first and place in time, or that somebody appeared confused, or they were, some restless at nighttime. And all of these things came together when we finally added the NLP. So the point is, you have to keep adapting and using the right tools for the right problem. So let me just talk about the clinical decision support lessons learned, and then we'll talk about a few other things before I bring it to a close. Bring the right team to the right patient at the right time. Think about it over and over again. AI doesn't make the diagnosis, but it identifies those who are most likely to have the diagnosis. We don't want to go to the FDA every time we do a predictive analytics tool. And our practitioners, they have licenses. And if the AI gets it wrong, that's a problem. We'll come back to that at the end. Think of it as augmented intelligence. That's less threatening to people than artificial intelligence because you want to help them do their job better, achieve higher safety, quality, better experience for our patients, and better healthcare economics. And then finally, the idea is not that we expect Epic, our electronic health record, or Cerner, or whoever you use, to be the be-all and end-all of predictive analytics in this case, but we do expect it to be a platform for communication, because that's where basically the nexus where everyone comes together. So let's talk for a moment about areas where we're not really mature yet. It's very difficult to engage with your patients. And conversational AI is something that we're beginning. Initially, we worked with a company called Avamo, but the point is, how do you connect with people out there? Mount Sinai will interact with nearly 6 million people this year in the New York area. Well, yes, 150,000 of those will be hospital discharges. Approximately 300,000 to 400,000 will be emergency room visits. Maybe half that number of urgent care. A lot of ambulatory. I mean, a lot of ambulatory. So when you put all those interactions together, you end up with a massive database and a massive number of people that have a lot of trouble getting their healthcare organized. If you don't know someone who knows the system, how easy is it to get a specialty appointment for your relative? Don't raise your hand because you can't. It's really hard. And so what we want to do is work with and use technology to make that simpler, because that's where we're still really, really not meeting the mark. And I don't think it's just Mount Sinai. I think it's an industry-wide problem. So think of it as an evolution towards an omni-channel experience. We want people to be able to access it whatever way works for them. Yes, there are going to be people who are only comfortable by phone, and yes, we have a call center. But wouldn't it be better if people were interacting with us through the Epic app that we rebranded as My Mount Sinai, or through a chatbot, or through other mechanisms that meet them where they are comfortable communicating? Now, let me move into risks. Bias. We train our data sets on biased data. Who has access to healthcare? Wealthy people, well-insured people? Yes, definitely. Underinsured people, undocumented immigrants in this nation? No way. It's very, very difficult. So when you're trying to establish the real source of truth, you have to be constantly skeptical about the fact that your algorithms are actually doing what you think they're going to be doing. And even with digital engagement, who has access to the internet? It's not poor people. So we have a mission. Mount Sinai was founded in 1852 as the Jews' hospital because Jewish doctors couldn't practice and Jewish patients couldn't get health care in a city where everything was faith-based. These days, it's a different group of people. It's the people of East Harlem that we serve in the Upper East Side campus, the people of Central Harlem at the Morningside campus. And so being able to serve people who are in the lower socioeconomic status rungs means that we have to rethink the way these algorithms work and be obsessive about assuring that we don't have algorithmic bias in our data sets. Now, here are the nurses in California protesting. Why? Well, I don't know. I live in New York. I don't live in California, but there's something different about California. Maybe it's the air, maybe it's the water, or maybe it's the fact that Kaiser didn't do a good job communicating with their nurses about how they were using AI. I don't know. It could be any of those. I'll be a diagnostician and say here's my differential diagnosis. But what I will say is that it's so important that we have to consider that people care about their jobs. They're threatened. And why would the nurses at Mount Sinai get involved with and want to be helping create a deterioration index that keeps people safer? Well, because that's why they went into nursing, was to keep people safe. But if you're implementing AI as a sort of a faceless corporate entity and people assume that you're doing it so that you can have more efficient care and take away jobs, then they're going to be threatened. And so I will paraphrase James Carville, political pundit, was made his name in the Clinton days, but still very active to this day. And what he would say in the 90s, when everyone was arguing how to win elections, his expression was, "It's the economy, stupid." And so what I would say to everyone here who cares about healthcare, it's the workflow, stupid. So forget about everything else. Remember, if it doesn't fit into the workflow, you're going to have these sorts of rebellions, because that's what's key and important. And the final thing I'm going to show you is a danger signal. This is radiology. Is there a profession more threatened by AI than radiology? Well, I don't know. We'll have, or I should say a specialty, probably not. And should they be? That's a question. I don't think so. I think they should see it as positive. It extends their ability to do more work, more accurately, but people are threatened. So the radiologists published a study where they used mammography readings, and then they intentionally introduced errors in this trial. In the second phase here, we see that red 12 mammograms on the left, they actually introduced 12 mistakes together with 28 where the prediction was correct, and the initial 10 where they sort of trained people. And what they found was fascinating here. If you look at the right side of this slide, when they introduced the errors, the residents, the inexperienced on the left there, that red bar, were wrong 2/3 of the time, maybe it's 3/4. It's a very significant number. People who were, relatively, junior, let's say they just came out of residency, still missed it 2/3 of the time. And even the experienced mammographers were led wrong half the time. So we are taking on a responsibility when we develop this brave new world of predictive analytics and digital tools that engage with people, that we cannot lead people the wrong way. And that's what those nurses are scared of, that we will lead them the wrong way. So governance, that's what it's all about. You must have a strict governance structure. AI doesn't rule us, we rule AI. And so we have a research AI committee, a teaching, learning, and discovery committee, a clinical and operational committee. And the whole concept is that with the executive leadership at the top and at the bottom, technology enablement and governance, we have to, and all of you have to understand that the only way we're going to be able to manage this is to remember accuracy, lack of bias, workflow, and governance. And so I'm going to end here with this last slide by talking about what is this future. We've only scratched the surface. We are not using the omics yet. We haven't brought in our massive genomic databases. We're not really using our imaging data in any significant way right now, except to work with companies to speed diagnosis of particularly deadly conditions. And so that's the promise. And with the computing power that we have, and with so many people, many of you here in the audience, many of you on this, whatever we have, whether it's Zoom or whatever platform, you have an opportunity to participate with us in building this new future. And we look forward to those partnerships, because it is the brilliance out there that will complement the brilliance that exists within Mount Sinai Health System, and using groups like Mount Sinai Innovation Partners as our window to the outside world, that we will be able to do wonderful things together. I want to thank you for allowing me to address you today.